The third module in this toolkit addresses stigma as it pertains to opioid use disorder, abbreviated as OUD. Stigma is extremely important to recognize and address because it creates barriers to treatment and marginalizes already at-risk populations. Stigma and shame create a nearly impenetrable barrier to the treatment and recovery process for individuals experiencing OUD. Stigma is associated with many mental health conditions and is a well-recognized problem. Although considerable progress has been made in recent decades in reducing the stigma associated with some psychiatric disorders, such as depression, such change has been much slower in relation to substance use disorders. Healthcare professionals are not immune to false beliefs and assumptions such as willpower should be sufficient to stop drug use. In fact, they may hold stigmatizing views of people with addictions that may even lead healthcare professionals to withhold care. It's important to understand that stigma plays a critical role in the nation's substance use disorder, or SUD, crisis. When internalized, stigma and the painful isolation it leads to encourages further substance use, directly exacerbating the disease. Many individuals suffering from OUD or SUD will neglect seeking medical care in order to avoid judgment and stigma, which they may have experienced when seeking medical care in the past. The following Montana State University faculty and staff helped create the content and graphics of this toolkit. Michelle Grokey and Allison Brennan served as principal investigators. Michelle is the Extension Health and Wellness Specialist, and Allison is the Extension Mental Health Specialist. This team is led by Program Director and MSU Extension Associate Specialist, Barbara Allen. Other MSU Extension employees responsible for the content in this module include Jennifer Munter, Program Manager, Barbara Watson, Program Coordinator, and Lori Mayer, FCS Administrative Assistant. Today you'll be listening to the third module in a 5-module toolkit developed by this project team and funded by the Substance Abuse and Mental Health Services Administration Prescription Opioid Awareness Grant and the United States Department of Agriculture Rural Health and Safety Education Grant. Throughout Module 3, our goal is for you, our participants, to walk away with a better understanding of stigma and be able to explain why it is so important when addressing OUD. At the conclusion of Module 3, participants will be able to identify the different types of stigma, recognize the effects of stigma on a person with OUD, identify strategies to lessen these effects, including reframing stigmatizing language, and finally, recognize the common myths and misconceptions surrounding the treatment of OUD. A general definition of stigma is a mark of disgrace associated with a particular circumstance, quality, or person. Terms such as shame, disgrace, dishonor, stain, taint, and blemish are all used to describe stigma. There are 7 types of stigma that are important to be aware of, the first one being social stigma. Sometimes referred to as public stigma, social stigma happens when society supports negative stereotypes and prejudices, which results in discrimination against others. Social stigma is defined as the disapproval of or discrimination against a person based on perceivable social attributes that separate them from other members of a society. For example, when a person is labeled by their illness or disorder, in this case, OUD. They are no longer seen as an individual, but as part of a stereotyped group. Negative attitudes and beliefs towards this group create prejudice, which leads to negative actions and discrimination. In 2000, James Dudley, author of Research Methods for Social Work, described stigma as stereotypes or negative views attributed to a person or groups of people when their characteristics or behaviors are viewed as different from or inferior to societal norms. The second type of stigma is called self-stigma. Self-stigma happens when a person with the negative attribute, for example, OUD, internalizes the social stigma. The third type of stigma is referred to as perceived stigma. This is the belief that others have negative beliefs about people with undesirable attributes like OUD or mental illnesses. The fourth type of stigma is one of the most harmful forms of stigma and is called label avoidance. This type of stigma occurs when a person avoids seeking treatment for their illness or disorder to avoid being stigmatized with a label. In this case, those with OUD might be labeled as a junkie or addict. The fifth type of stigma is referred to as stigma by association. This type occurs when someone is linked in some way to a person with a stigmatized illness or disorder, and the effects of this stigma, therefore, are also felt by them because of their association. The sixth type is called structural stigma and happens when public policy or other societal structures are in place in such a way that people with a stigmatizing illness or disorder experience decreased opportunities. And lastly, health practitioner stigma occurs anytime a public stigma negatively affects the care received by someone with a stigmatized illness or disorder, such as OUD. In a national poll conducted by the American Psychiatric Association in 2018, 46% of Americans, that's almost half, said the opioid crisis is impacting people just like them. And in 2018 alone, the total estimated cost to society due to the epidemic was hundreds of billions of dollars. Statistics such as these have inspired the MSU Extension Opioid Project team to adopt the program theme, "We're all in this together." This theme has guided the team throughout their grant activities. The 7 types of stigma create an us versus them society, and this divide leads to disparities in health and social outcomes. When stigma exists, diagnosis, treatment, and successful outcomes for those with OUD are not effectively achieved. Stigma and othering can also result in lower economic and political status for individuals with substance use disorders. For example, stigma can adversely impact employment, income, and public views about allocation of resources. By adopting the mindset that we are all in this together, we can stop the us versus them divide, come together, and end the cycle of stigma for those with substance use disorders like OUD. This image does a good job depicting the cycle of stigma and what can transpire when negative labels are placed on individuals with OUD. Now that we have discussed the types of stigma and introduced some of the outcomes of stigma, we can dive deeper into the harmful effects of stigma. Let's begin with a quote. Irving Goffman, a social psychologist and writer, said, Stigma is a process by which the reaction of others spoils normal identity. He went further to define stigma as an attribute that is deeply discrediting, that reduces someone from a whole and usual person to a tainted, discounted one. Substance use disorders, including OUD, remain extremely undertreated. Stigma can reduce willingness among policymakers to provide resources. It can reduce willingness of healthcare providers to screen for and address substance use and opioid use problems, and it may limit the willingness of individuals with SUDs to seek treatment. These factors contribute to so few individuals with SUD or OUD receiving treatment. Public education that reduces stigma and provides information about OUD treatment and recovery is needed. Research by Naomi Eisenberger at UCLA helps us understand the profound role of the social environment in substance use disorders. Dr. Eisenberger has found that social pain is processed in some of the same brain areas that process physical pain and is suppressed by pain relievers. Additionally, an article by Venero and colleagues reported that when given a choice between self-administering a drug and interacting with another animal, methamphetamine or heroin-dependent rats chose the social interaction. However, when they were punished for the social choice with an electric shock before the interaction, the rats reverted to choosing the drug. Lastly, stigma inherently reduces an individual's self-worth and self-value, making it less likely they feel confident and empowered enough to seek employment, housing, education, and services. Lack of information creates prejudice, avoidance, rejection, and discrimination. For this reason, education becomes a powerful weapon for reducing stigma. Inform yourself so you are better equipped to inform others. Reputable and reliable information about substance use disorders, including OUD, is located on agency websites such as Centers for Disease Control and Prevention, www.cdc.gov, the National Institute of Health, www.nih.gov, the National Institute on Drug Addiction, www.drugabuse.gov, and the Substance Abuse and Mental Health Services Administration, www.samhsa.gov. People who are battling OUD sometimes lie or steal and can demonstrate aggressive behavior, especially when experiencing withdrawal or intoxication-triggered paranoia. These behaviors are transgressions of social norms that make it hard even for their loved ones to show them compassion, which helps explain why strangers or healthcare workers may be rejecting or unsympathetic. The behaviors witnessed from people with OUD can be challenging, but don't give up. There is hope for recovery. Opioid use disorder does not discriminate. It can and does affect people from all walks of life. Treat them the same way you treat others and the way you wish to be treated. Model respect. Look at the whole person. OUD is only one part of who someone is. They may also be an artist, a friend, someone's son or daughter, extremely hardworking, kind, and compassionate. Everyone deserves love and respect. Words have the capability to heal or to hurt. Referring to a person with a substance use disorder as a junkie, drunk, crackhead, or similar words is a form of negative labeling, and labels create stigma. Consequently, this treatment results in the individual turning to substances in order to cope with the overwhelming shame that comes along with a substance use disorder. In 2013, a National Drug Policy Reform Summit was held at the White House in an effort to reduce the stigma towards people with substance use disorders. The summit addressed various issues, including the importance of language relating to drugs and substance use. Examples of non-stigmatizing language are provided on the next slide. As you review the examples provided, try and imagine yourself being the one battling a substance use disorder. Language matters when it comes to the public at large, as well as the person with a substance use disorder. Person-first language doesn't define a person based on any medical disorder that they may have. It's non-judgmental, neutral, and defines the disorder, not the individual, in a purely clinical way. Person-first language reduces stigma and ultimately improves treatment and recovery outcomes. Remember, it's not about being sensitive or polite or even politically correct. It's about having a positive societal impact through language. This slide demonstrates terms that are stigma reinforcing and we want to avoid using compared to stigma reducing language, and offers some potential substitutions that you can use to help reduce stigma. For example, you see the terms addict, junkie, tweaker, alcoholic, drunk, and lush under the category of stigma reinforcing language. Alternatively, we can reduce stigma by using terms like person with an addictive disorder or person with alcohol use disorder. Substance abuser is another term that you might hear that ends up promoting stigma. Instead, we could refer to someone as a person with a substance use disorder. It's important to note here that clinicians are subject to systemic bias when the terms abuse and abuser are used. Substance abuse implies willful misconduct, whereas having a substance use disorder implies medical malfunction, which associates with less blame. Another poignant example to demonstrate how the way that we talk about substance use often differs from the way that we talk and think about other kinds of disorders is that we never refer to people with eating disorders as food abusers. Why do we refer to people with substance-related problems as substance abusers? Some additional terms that you might see used to describe substance use and conditions associated with substance use could be relapse or dirty drug screen, the term clean. And so here we want to use language like return of symptoms, resumption of use, or flare-up. Try not to use the terms dirty or clean when referring to a drug screen. Instead, you can simply state the drug screen tested positive for a specified substance, or you could say a person who is in recovery or who is abstinent from substances or other addictive behaviors. And then lastly, we have some common terms such as dependence or chemical dependency. Again, using that person-first language, person who has a substance use disorder. And then lastly, substance abuse treatment, chemical dependency treatment, and rehab. Instead of using those terms, we could substitute substance use treatment or addictions treatment. Comments from members of the professional community who have experience with individuals with substance use disorders such as OUD. The first is a comment from a police officer who stated, "I would be more than happy to help somebody. I would give as much help as I could if somebody did come up to me and say, 'I need help with meth. I got a meth addiction or opiate problem.' I definitely get them on the right track to get help. What I could do, I guess as much as I could do." The next is from a medical provider who said, "I wish it wasn't so stigmatized and shameful of an experience for people. I think we are all in some level of recovery in our lives, and so whether it be drugs or whatever, so I wish that we embraced our communities in a more loving, supportive way, because that makes a huge difference." These are personal experiences of individuals who have experienced some type of stigma due to OUD. You can tell whenever I'm in line or at the store or something, they just treat me a little differently than everyone else. I notice they'll say hi to everybody else in line, and then they get to me and they make this grimace. It's just one of those things. It's subtle, but you can tell they don't really treat me like everybody else. They don't have any respect for me. I get respect is earned or whatever. I wish I wouldn't have been so public about my use. I would pass out on park benches and stuff like that. It wasn't a good time. They still harbor a grudge over it, I guess. It's pretty sad. I have a sister that judges me because I'm an addict, recovering addict, I should say. So I know how it feels to be judged about it every day. She treats me different. And when she found out that my son was in withdrawal because of the medicine I was on, I just can tell by her body language that she was just disgusted with me. And she's only seen my son like twice. So I just feel like she doesn't want to come around because she doesn't like the fact that I used drugs at one point. The reality of substance use disorders is that the onset is often due to a combination of genetic, physiological, and environmental factors beyond one's control. Also, chronic use of substances like prescription opioids can have an altering effect on parts of the brain that control impulse, judgment, and the ability to control one's use of a substance. Substance use disorders such as OUD are not usually standalone issues. Depression and anxiety are often underlying conditions that contribute to the onset of use, the persistence of use, and the resumption of use. The presence of two or more disorders is referred to as co-occurring or comorbid disorders. Research shows that many addictions have an underlying cause, usually a mental illness. The National Institute of Mental Health reports that nearly 45% of those with one mental disorder meet criteria for having two or more disorders. That means, when left untreated, a mental illness can make it difficult to achieve long-term substance use disorder recovery, and when left untreated, a SUD or behavioral addictive disorder can make it difficult to achieve long-term mental wellness. There are two basic approaches to substance use treatment: abstinence-based treatment and medication-assisted treatment. Medication-assisted treatment, or MAT, is primarily used for the treatment of alcohol use disorder and opioid use disorder. The prescribed medication in MAT operates to normalize brain chemistry, block the euphoric effects of substances, relieve physiological cravings, and normalize body functions. Co-occurring disorders are identified and addressed through counseling and behavioral therapies that are provided in conjunction with the FDA-approved medications. Retention in methadone and buprenorphine treatment is associated with substantial reductions in the risk for overdose mortality in people dependent on opioids. Despite overwhelming evidence for the effectiveness of medication-assisted treatment, there is a large population of people with opioid use disorder who remain untreated. There are challenges to expanding access to OUD medication despite the urgent need for treatment throughout the United States. Only about 21.5% of people with opioid use disorder received treatment from 2009 to 2013. There are two compounding elements of stigma at play here. The first area of stigma involves the individuals themselves, and the second area of stigma involves the use of opioid-based medications to treat people with opioid use disorder. These overlapping and compounding effects of stigma cause those with opioid use disorder to seek other, maybe less effective treatment alternatives or no treatment at all. Recently, to incorporate language that reduces stigma, the treatment of opioid use disorder has been referred to as MOUD, or medication for opioid use disorder. To reduce the stigma surrounding MAT, we must first understand MAT. A 2019 CDC publication outlines 3 approaches used in MAT. First is stabilization and opioid withdrawal management, followed by medication maintenance, and combined with behavioral therapies. Stabilization and opioid withdrawal management is a process in which providers offer medications such as methadone, buprenorphine, or naltrexone on a short-term basis to reduce physical withdrawal symptoms. Formerly called detoxification, this process gradually decreases the dose until the medication is discontinued, typically over a period of days or weeks. Patients who complete medically supervised withdrawal are at risk of opioid overdose if medication maintenance is not utilized. Abstinence leads to a diminished physiological tolerance to the opioids, so they no longer know what dose of the drug they can safely tolerate and then run the risk of respiratory failure. The best results occur when a patient receives medication for as long as it provides a benefit. This approach is often called maintenance treatment. Once stabilized on OUD medication, many patients stop using illicit opioids completely. Others continue to use for some time, but less frequently and in smaller amounts, which reduces their risk of overdose death. OUD medication gives people the time and ability to make necessary life changes associated with long-term remission and recovery, such as changing the people, places, and things connected with their drug use. And they're able to do so more safely. Maintenance treatment also minimizes cravings and withdrawal symptoms, and it lets people better manage other aspects of their life, such as parenting, attending school, or working. Because the maintenance medications used in MAT are themselves opioid agonists and can produce euphoria in people who do not have an opioid use disorder, many people have assumed that this form of treatment substitutes a new substance for an old one. This lack of understanding has hindered the adoption of these effective treatments. In the past, even some inpatient treatment programs that were otherwise evidence-based did not allow patients to use these medications in favor of an abstinence-only philosophy. At the doses these maintenance medications are prescribed, withdrawal symptoms and cravings are minimized, making it possible for the patient to function normally, attend school or work, and participate in other forms of treatment or recovery support services to help them become free of their substance use disorder over time. The aim is to wean the patient off the maintenance medication. This should be done jointly between the treatment provider and the patient and needs to happen at a gradual pace. It may take months or years in some cases. Just as body tissues require prolonged periods to heal after injury and may require external supports such as a cast and crutches or a wheelchair, brain circuits that have been altered by prolonged drug use and substance use disorder take time to recover and benefit from external supports in the form of medication. In cases of serious and long-term OUD, a patient may need these supports indefinitely. This is a testimonial from a provider on the perspective of MAT or MOUD. So I think what I find with those kinds of steps, they really established a strong relationship, and the medication makes such a huge difference. Once they've been stabilized on medication, they're much more open to counseling. And it's really cool having a team effort because there's been a couple patients where we're all on the same page and the person has a crisis and then we're able to talk to each other and figure out what everybody's doing. I just can't get over how people's lives change so miraculously. Unbelievable. Holding jobs, taking care of their kids, it's just great. And here is a testimonial from a patient regarding MAT or MOUD. Okay, I would say it's not a drug. It's more like a stepping stool, like a crutch that you can use so that you can go to work and do stuff at first. You can get away from all kinds of people so you can get out of that scene because you already have that part that makes your brain and body okay. You don't have to go and look for that, you already have it. So you can spend your time, instead of looking for drugs and spending all your money on drugs, you can go out to eat and do normal things. And here we have testimonials from MAT providers and administrators. I would definitely say it can be really stressful, especially when you are initially starting patients. Our program is really nice, and I feel like we have a lot of support from upper management, that we're not getting pushed to just take on as many MAT patients as humanly possible. Historically, we're not a harm reduction agency outside of medication-assisted treatment. Folks that are enrolled in our services are asked to abstain or do their best to abstain. We will work with relapses, we'll work with that stuff. But if somebody comes in and says, I want my Suboxone, but I'm also going to continue to drink potentially or smoke marijuana, what happens to those folks? So what does that look like? So that's kind of the question that I've had for our different MAT teams. MAT has been researched extensively and is considered the gold standard for treating opioid use disorder. However, there are a number of myths and misconceptions surrounding MAT that have increased the stigma associated with this type of treatment. The definition of myth is an unfounded or false notion, a widely held but false belief or idea. Myths contribute not only to the stigma surrounding substance use disorders like OUD, but also to the stigma related to the medications used to treat OUD. The following slides will cover the common myths and misconceptions that have contributed so significantly to the stigma associated with MAT. Before we continue, take a moment to pause this presentation and watch this brief 6-minute video about the common misconceptions held by service providers. This is a beneficial video to share with substance use and mental health prevention, treatment, and recovery providers, as well as healthcare providers and agencies that provide services to families. The first myth or misconception we will cover is that MAT medications pose a diversion risk. If you recall from previous modules, prescription drug diversion is the deflection of prescription drugs from medical sources into the illegal market. This includes transferring drugs to people they were not prescribed for. The opioid-based medications used in MAT are slower acting than opioid-based drugs prescribed by doctors. In fact, only 15% of diversion reports involve the maintenance medications used in MAT, while 67% of reported diversions involve oxycodone and hydrocodone, medications typically prescribed after surgery. The myth that MAT is trading one addiction for another is completely unfounded and false. It's important to understand that the goal of MAT is to wean patients off opioid drugs, both prescription and illicit, while avoiding the painful and debilitating symptoms of withdrawal. These medications eliminate the need for the patient to seek opioid-based substances outside of medical care. Unlike drugs of abuse, such as heroin or prescription painkillers, methadone and buprenorphine, medications utilized in MAT, do not create the feelings of euphoria that contribute to uncontrollable drug-seeking behavior because they are provided at a therapeutic dose under medical supervision. When taken as directed, these medications fulfill the brain's craving for opioids, allowing individuals to retain day-to-day function and participate in treatment. The fact is, the research indicates that a combination of medication and behavioral therapies can successfully treat substance use disorders and help to sustain recovery. MAT bridges the biological and behavioral components of OUD. The information on this myth versus fact slide came from the National Council for Behavioral Health. The myth that MAT is only for the short term is also false. Research shows that patients utilizing MAT for at least 1 to 2 years have the greatest rates of long-term success. Currently, evidence does not support the benefits of strict cessation when treating OUD. Patients with long-term abstinence can follow a slow taper schedule under a physician's direction when free of stressors to attempt dose reduction or total cessation. The myth that MAT increases the risk for overdose in patients is false. The fact is, MAT helps to prevent overdoses from occurring. Opioid tolerance increases with repeated use over time. When the use of opioids ceases, tolerance decreases, thus putting the patient at a greater risk for overdose, even with a single use of opioids. Changes in tolerance from not using or using less happens after being in jail, detoxing, or following any period of abstinence. In a meta-analysis study of drug-related deaths soon after release from prison, a 3 to 8-fold increased risk of drug-related death, especially in the first 2 weeks after inmates are released, was shown across multiple countries and states, including the United Kingdom, Australia, Washington State, and New Mexico State. The myth that providing MAT will only disrupt and hinder a patient's recovery process is also false. MAT has been shown to assist patients in recovery by improving quality of life, level of functioning, and the ability to handle stress. Above all, MAT helps reduce mortality while patients begin recovery. Some doctors may believe their patient's condition is not severe enough to require MAT. The fact is, MAT utilizes a multitude of different medication options, including agonists, partial agonists, and antagonists that can be tailored to fit the unique needs of the patient. The myth that there isn't proof that MAT is better than abstinence is false. There is an overwhelming amount of information and data supporting MAT as the gold standard in evidence-based treatment for OUD, and MAT is the recommended course of treatment by the National Institute on Drug Abuse, the Substance Abuse and Mental Health Services Administration, the National Institute on Alcohol Abuse and Alcoholism, the Centers for Disease Control and Prevention, and many other agencies and organizations emphasize MAT as the gold standard of treatment. The final myth we'll address is that most insurance plans don't cover medication-assisted treatment for opioid use disorder. The fact is that as of May 2013, 31 state Medicaid FFS programs covered methadone maintenance treatment provided in outpatient programs. State Medicaid agencies vary as to whether buprenorphine is listed on the preferred drug list and whether prior authorization is required, a distinction often made based on the specific buprenorphine medication type. Extended release naltrexone is listed on the Medicaid preferred drug list in over 60% of states. The ability to speak exactly is intimately related to the ability to know exactly. This quote from Wendell Berry concludes our presentation on stigma and opioid use disorder. If you are interested in learning more about medication-assisted treatment and other treatment and recovery approaches, please refer to the bonus module, Opioid Use Disorder, Treatment and Recovery Approaches. Thank you all for your participation, and remember, what we think we know may not be correct, and it may inhibit us from learning the truth. The best way to eliminate stigma is to get correct and timely information and share that information with others. This concludes Module 3. For more information on prescription opioid use and misuse in Montana, you can visit our project website. Our website will allow you to access the other 4 modules and their associated PowerPoint presentations, the Native American Toolkit, and several informational and recovery story videos. You can also print or download our educational resources and order a medication disposal pouch while supplies last. If you have any questions, or if you know of an organization that would benefit from this toolkit or would like to present the toolkit to their communities, please email our program director, Barbara Allen. Thank you for listening today, and we hope that you have gained knowledge and awareness on the topic of prescription opioid use and misuse.